Fabulous. Thank you all for assembling for this meeting. And I think we will get started. We may still have some folks joining us. We have all of our brilliant panelists assembled here now. My name is Mark Misrock, and I use he and they pronouns. I am the executive director of the National Working Positive Coalition, and I serve as the co-chair along with the magnificent Vanessa Johnson of this working group, the Structural Interventions Working Group of the Federal AIDS Policy Partnership. The Structural Interventions Working Group grew out of what was once called the Housing Working Group and became focused on the constellation of key structural factors, social determinants of health, political determinants of health, beyond the biomedical factors that have been so essential in focus in our domestic response to and international response to HIV in this country. I am deeply appreciative of the brilliant folks who have agreed to join us today for this super important meeting. I am among what I'm imagining are many people who are truly anxious about what the very soon implementation of what's called the Medicaid Community Engagement Requirements, really Medicaid Work Requirements, mean to people living with HIV, to people with reasons for HIV prevention, to everyone in this country who gained access to health care and treatment through Medicaid expansion. I'm super grateful that Rachel Klein from the AIDS Institute has brought her brilliance into this meeting and her very extraordinary knowledge about this policy development and ideas for advocates to respond to help kick us off. We are going to plan the meeting around a focus on Vanessa discussing discussing our webinar goals. Rachel will then give sort of an overview of the meeting, and so with that, we will go into discussion, including our brilliant panelists and each of you. And I see quite a lot of extraordinarily brilliant people assembled for this meeting, and I'm grateful that you have. I want to turn it over now to Vanessa Johnson.
Hey, thank you, Mark, and welcome everyone to today's what we hope to be very fruitful strategy discussion on Medicaid work requirements. As Mark has already said, and I won't belabor the point, that this webinar will be broken into three sections, with Rachel starting with giving an absolutely brilliant overview of the Medicaid work requirements so that we all can understand, have a baseline knowledge of that, so that we can join in a discussion with our panelists. We have some outstanding panelists, and they will come back for two parts. The first part, they're going to talk about the community impact that these Medicaid work requirements will have on all of us, even those who may be covered, have their own insurance. This is going to profoundly impact everybody in some way. The last piece is advocacy and action. And so what we're hoping that you will leave this webinar today with knowledge, additional knowledge about the Medicaid work requirements, understanding of how this is going to impact our community, and leave with a charge that you personally will attend to ensure that not just yourself, if you're on Medicaid, retain your Medicaid benefits, but those around you who may or may not be on Medicaid have the information they need to share with loved ones. Because this is not just for us living with HIV. This is impacting everyone. So let's just keep that in mind. And with that, we're going to start, but I'm going to do a shameless plug. I have to do it because it's important. And Barb is just a woman who's going to do it. Barb, as co-founding member of the Positive Women's Network USA, I want to thank all the PWN USA representatives on this call today and congratulate all of us on 18 wonderful years of advocacy and action. Would you like to make a plug so that we can get this fundraiser started? That's right, it's my shameless plug. I can do it. Go ahead.
Yes, I will absolutely follow along with the shameless plug. Hi, everybody. Barb Cardell. I use they, them pronouns. I have been a member of PWN for 17 years. I joined a year after the founding, so I call myself founder adjacent. And I just want to lift up that PWN is a membership group that is led by and for our members, which are cis and transgender women, gender diverse and transgender folks, leading advocacy, lifting up our voices in ways that are so compelling and so necessary. We are a place where people come to learn about advocacy, to develop as leaders, and to ensure that the true intentions of the Denver principles, that we lift ourselves up as the subject matter experts, not as victims or patients or clients, and especially, God forbid, not as consumers. So PWN is 18 years old, and we have been really a part of so many incredible and profound advocacy opportunities. And we want to invite you to donate $18, $180. If you got $18,000, we will take it gladly. We want to lift up PWN's birthday and thank everyone who has both been a member and has been an ally. We know that it is community that has helped us live, thrive, and survive for as long as we have. And so, yep, we got the link in the chat. Thank you all so much. And with that, Vanessa, I'll pass it back to you. And thank you for being one of our founding members, one of our visionaries, and one of our incredible community members who continues to lift up the voices of all of us with both the caucus as the spark and with PWN as a founding member. I'm just going to say, Vanessa, sorry, got to brag on you, my friend. If there is an incredible advocacy opportunity in HIV community spaces, Vanessa was either a founder, a visionary, and certainly a spark of it. And so thank you, Vanessa, for being such an incredible, incredible advocate for all of us. Because of you, we are here, we thrive, and we continue to be here.
You're so welcome, Barbara. You almost got one of my famous "Can we move on?" Okay. Thank you. I appreciate all those great words and definitely PWN. So, Rachel, are you ready? You have 20
Sure
minutes.
am.
Rachel, the floor is yours.
All
And then
right.
if you have time, will you have like 5 minutes in case someone has follow-up questions or there's questions in the chat that Mark and I and Heather are looking for?
I will be here for the whole meeting.
Oh, great, because I thought you were leaving.
So, yes.
Go ahead.
And I just want to say, first of all, how thrilled I am that PWN is doing the big 18th birthday. I'm sure that you did this with full knowledge that in the Jewish tradition, 18 is chai, it means life. And that's why it's so exciting. And I appreciate you, Barb, asking for multiples of 18 in your donation request is perfect. Okay, so let me go ahead and so we can start the slides. Not sure. Okay, great. And you can just skip to the next one. So many of you have probably seen me do this presentation before, and I will apologize in advance for any repetitious information. Probably much of it is repetitious to many of you. I will endeavor to go through it quickly so that we can get to the important part of the conversation and the strategy session. But I do think it's important just that everyone has a grounding in this tremendous change that is about to happen to the Medicaid program because it is such an important program for people with HIV. More than 40% of people with HIV are enrolled in Medicaid. Medicaid provides 45% of all federal funding for HIV treatment in the US. That is actually 5 times as much on an annual basis as is appropriated to the Ryan White program. So Medicaid is tremendously important, both for individuals and also as a way to help fund Ryan White, because when people who are enrolled in Medicaid use Ryan White providers, they're able to get reimbursed from the Medicaid program, and that enables Ryan White dollars to be stretched further to take care of expenses that are not covered by Medicaid. I also want to flag that Medicaid enrollees with HIV are more likely than other Medicaid enrollees to have co-occurring conditions like substance use, mental health conditions, and other comorbidities. And that's going to be really important as we talk about what our this new work requirement is and what some of the exemptions are from that work requirement. So let's move to the next slide. So I'm sorry, some of my formatting just isn't making it through. I promise on my screen it looked great, but I will just apologize in advance to everybody for that. So you can see here that the Medicaid work requirement is coming to a state near you. There are only 7 states that do not have to implement a work requirement, and that's because they did not do Medicaid expansion or anything that even remotely looks like Medicaid expansion. There are a few states that don't technically have Medicaid expansion that are subject to the new work requirement, and that is because they have a program through a waiver before the ACA or something since then that sort of looks like Medicaid expansion but isn't exactly the same, and that includes Georgia, where they did a moderate expansion of Medicaid with a work requirement before all of this was required. Tennessee that did the TennCare expansion for adults before the ACA, and Wisconsin that did a similar thing. So those are all the states where this is going to have to be implemented. It's most of them, but you happen to live in Texas or Florida, or Wyoming or South Carolina, etc., then your job is to make sure that nothing like this happens to your state, unless, of course, they decide to expand Medicaid. Next slide. So what is, I've been calling it a work requirement. The law calls it a community engagement requirement. And basically what it is a new requirement in Medicaid for adults, so people ages 19 to 64, who are enrolled in this Medicaid expansion group or a waiver that requires you to participate in at least 80 hours of work, school, or some volunteer activity, or a work program. So those are the kinds of things that people will have to do in order to meet this. It has to be at least 80 hours a month, depending, but your state can choose more if they want to. Or if you have income that is at least $580 in the month for your household, then that will also qualify you. So $580 a month is 80 hours of work at the federal minimum wage. If you live in a state that has a higher minimum wage than the federal minimum wage, then it could be less than 80 hours for you, as long as you've met that $580. One other tidbit that is, I think, really useful is that we now know that, that $580 is for your Medicaid household, because the way that income is determined for the Medicaid expansion group, it works differently than other Medicaid categories. And we use something called MAGI, which is modified adjusted gross income, which is based on your tax return. Because the Medicaid expansion needed to flow clearly to the ACA premium tax credit group. And so we sort of did a lot of work to align the Medicaid income eligibility with the ACA and use this tax return information. So that means that if you are in a household that has 2 adults who could be subject to this work requirement, if you are part of a MAGI group because you're married, or for another, or because there's a dependent situation, then that $580 covers the household unit. happy to talk more about that. It can get really complicated, but I think it's just something that we want to flag, because in a lot of the states that this covers, you know, we have a higher minimum wage than the federal minimum wage, and this is a way that, you know, more people can meet this requirement without having to have everybody in the household working at least 80 hours. Next slide. So how is it going to be assessed? So the way it's going to work is that at your initial enrollment, so the application, or at the first re-enrollment after this all gets implemented, the state has to look back to assess whether or not you were in compliance with the requirement in the 1 to 3 months preceding that application or initial renewal, or if you were exempted or excluded from that in those 1 to 3 months. Most states are choosing to make that a 1 month look back period, and so it's just in the month immediately prior to application, but states have the ability to look back further, and there are a few who are choosing to do 2 or 3 month look back periods. Once you're enrolled in Medicaid and or we're further down the line from the initial implementation, then the states are going to have to do renewals every 6 months. That's another component of this whole big change that we're doing. That was a different component of HR 1, but every 6 months, states have to do a renewal for all of the Medicaid enrollees. And then the states are going to have to look back in between, like between this renewal and the previous renewal 6 months ago. Was there at least 1 month when you were deemed to be a person subject to the work requirement, and did you in fact meet that requirement during that 1 month? And it can be any month in that 6 month window that you have to meet this. Now, states can choose for that to be 1, 2, 3, 4, 5, 6 months. That you have to meet this qualification in between renewals. Again, most states are right now choosing to that 1 month to be as least restrictive as they can be. Next slide, please. Other provisions of HR 1 that you should know about is that, number 1, the work requirement is not waivable, and that is both good and bad. It's good because it means that states that it doesn't apply to can't suddenly decide to opt into it, and so that's great. It's bad because it means states can't, you know, decide not to do it, and they also can't add other groups to the work requirement, and they also can't add exemptions from the work requirement that are not already in the statute. So waivers are just a common way that states make changes to the program. They ask CMS permission to do something in their Medicaid program that the law doesn't otherwise allow, but you can't do that with work requirement. There are a whole bunch of mandatory exemptions we're going to talk about in a second. States have to implement those. They can't choose not to do that. The law does require that states use ex parte verification where possible. What does that mean? That means that states have to look at all of the data that they have available in their systems that could tell them whether or not somebody has either met the requirement, is subject to the requirement, or is excluded or exempt from that requirement. And they have to do that without contacting the enrollees to ask them to show their status before they have looked at all of this other stuff that is available to them. So what kind of data is available to states in general? You know, they have a lot of access to wage and income data. They have access to all of the data that is already reported to Medicaid. So claims data, for example, diagnosis codes. They may have access to or have a memorandum of understanding with their Department of Health where they could check an HIV registry, for example. There are lots of other things that states have access to already. But it is different from state to state. So we may find that there are some places where some states have decided that they want to be able to have access to lots of data, and some states who are like, no, we're just going to do the bare minimum here and then go to people to have them tell us whatever we don't know. If you are otherwise eligible for Medicaid expansion, except that you are subject to the work requirement and you don't meet the work requirement, you get cut off. You may not go to the marketplace to get coverage there. You're ineligible for the marketplace because you did not meet the work requirement. And then we already talked about redeterminations. So next slide. So here is this relatively long list of people who are excluded from the Medicaid work requirement, and people might fall into more than one of these categories, right? I can definitely see how somebody could be a disabled veteran who is participating in a drug addiction or alcohol treatment and rehab program. You might have SNAP and Medicaid. You might be a person who, was in foster care and someone who is getting SNAP, right? So people are going to fall into multiple of these categories potentially. And it's a little unclear what that means when you fall into more than one of these categories. But my hope is that states will sort of look at this and take a category that has a longer duration over one that has a shorter duration in order to be able to apply that to people. States have to look at all of these factors when they're determining whether or not this requirement applies to somebody. That orange box in the bottom left-hand corner is supposed to be over medically frail or has special medical needs. This is the exemption exclusion that we have been focused on the most because we'll go on to the next slide. I'll just say that for right now. That's the one that was supposed to be highlighted there. This is one of the ways that people can be excluded from the work requirement is if they are quote unquote medically frail or have special medical needs. And the statute outlined 5 different categories of people who could meet this exemption, including people who are blind disabled, have a substance use disorder, have a disabling mental disorder, physical, intellectual, developmental disability that significantly impairs their ability to perform one or more activities of daily living, or they have a serious or complex medical condition. So we've been really, really focused on this because HIV is both a serious and a complex medical condition. And so we have been working with states and with the federal government, urging them to be very clear that HIV does count as a serious and a complex medical condition, and that people with HIV should be exempted. However, we had a new stumbling block put in front of us when HHS issued their interim final rule on January 1, because they added a new restriction to these exemptions that did not exist in the statute. So they've gone further to restrict who can qualify as someone with special medical needs by saying that in order to be exempt, you not only have to have one or more of these conditions, but the condition has to significantly impair your ability to meet the work requirement. That's really, really different. And it is exactly what we were hoping to avoid, which was having to have some kind of a severity of illness test or an ability to work test at all that would require people who are living with HIV to be subject to this requirement. Next slide. States have the ability to also have optional short-term hardship exemptions for people who would otherwise be subject to this requirement. States don't have to have these short-term hardship exemptions, but if they do, they have to respect all of them. So they can't sort of pick and choose between these. There are a couple of states who've already said that they're not planning to implement these, but we think most of them are going to probably take up the option. It's really high. If you are a state where you have an area in your state with really high unemployment, it is hard to then require people to work at the risk of losing their health insurance. So, I think that these are all pretty, or if you are in an area, let's say you are in a state that gets hit by a hurricane and, your community is decimated, you would be really hard pressed to also show that you're in compliance with the work requirement during that period of time. So there are more ways that people can be exempted. Next slide. So I talked a little bit about ex parte verification and data matching a minute ago. There, as we said, there are required where possible. We know that there are some clear sources of data when it comes to the medical exemptions that include claims data for Medicaid, diagnosis codes, other state data sources, which could include public health department records where there is a memorandum of understanding and the ability of the Department of Health to talk to the Medicaid agency. Obviously, providers are a source of verification about whether somebody has a disabling condition or a serious or complex medical condition. And all of these things have to be documentable, right? So the state has to put together a process that evaluates whether somebody is medically exempt, I will say for ease of wording, and it has to be auditable, which means that the state is going to have to figure out ultimately a source to apply to prove that they did it right and that they exempted people who should be exempted and didn't exempt people who shouldn't be. One of the really crucial ways that states can do that is by allowing self-attestation, right? People can say, I have a condition that should exempt me from this requirement. And states can allow that at application or at renewal or anytime that an enrollee requests it, right? So if you are diagnosed in the middle of your renewal period and you want the agency to know that so that you can be exempted, then you would be able to request that evaluation, in between renewals. Self-attestation is allowed today. It is allowed in 2027, but starting in 2028, it's restricted so that states can only allow someone to use it once, I think in a 12-month period, and then they have to actually go back and verify what the person said if they've allowed that self-attestation. So it's something that I really wanted to flag because I think it's going to be really important, especially for states that are going early this year and when states are initially implementing in 2027, because there's just going to be so much chaos and confusion that it's going to be really important that we get states to allow self-attestation to the broadest extent possible for whenever they're allowed to do that, and specifically, in that first year as everything is sort of getting going. And of course, there are third-party vendor services that have all kinds of data that states are able to purchase if they choose to spend money that way. But, not all states are going to use that third-party documentation processes. Next slide. And I'm so sorry, I can't keep up with the chat and this at the same time, but I will look at it as soon as I'm done talking. Timeline. States have to start enrollee outreach by September unless they're going sooner than January, right? So that's sort of the latest that they're going to start doing outreach to people. They have to send notices out pretty broadly 3 months before they're starting their requirement. So, and that begins on January 1 unless a state gets approval to delay implementation, but HHS has said that they're probably not going to approve very many of those requests if they get them. Next slide. So there's a lot that states are doing right now. They have to sort of figure out what all these things mean. And right now they're all going back to the drawing board a little bit because we all thought that the HHS interim final rule was going to put some better parameters around things like what constitutes a serious or complex medical condition and say, HIV is one, right? And maybe name some of the other ones. But they didn't do that. They just said states have to make lists. They have to make good lists. We'll evaluate whether that list is good or not later on when we decide what it looks like, what it means. And they have to, figure out which of these conditions is going to make someone unable to work. So they kind of have to do that on their own. And now a lot of them are sort of going back to the drawing board to figure out what to do about that. They have to decide the terms of all of these discretionary pieces of this program. You know, the Medicaid is a federal state partnership. So the federal government sets out these rules and then says to states, go implement them and create a program and administer it. So it's up to states to do all of the stuff that they have to operationalize on the ground. So they have to figure out what conditions are on their list, what are the verification processes, how many hours do people need to be compliant, what's the look back period, all of these things that we've been talking about, and how do we operationalize any of this? How do we, you know, we've got to develop member notices and training manuals and public facing policy guidance and update our IT systems and figure out what this application looks like and create all these data sharing agreements. And they've got to train their staff. So states are very, very busy right now. And this HHS interim final rule that kind of changed the game on them in the middle is not helping. So there are a lot of states that were sort of moving along, and now they have to go back and kind of figure out this this test about whether or not people can work. Next slide. Most states, so as I said, most states are still in decision-making mode. This is a findings from a survey that KFF did before the interim final rule came out. And it was sort of describing, you know, where states were at with a bunch of these decisions. And basically what it shows is that, you know, most states are choosing less restrictive policies where they can. They are, trying to be broad in the data sources that they are planning to use, but they are also, you know, really stymied by budget problems, which are, you know, preventing them from hiring lots of new staff to help implement this. So I think, you know, we're really concerned that given how close we are to implementation, that it could be really, really messy when this all starts unrolling. Next slide. This is an example of like how this flow could work if you were in a state trying to figure out how to like implement this. And I built this based on what Nebraska had done. But of course, Nebraska, which started first, May 1, it has to now go back to the drawing board. So they had sort of built this whole system based on like, do you have a medical exemption? You know, yes or no. And then we're going to check all of our records, but 90 days before renewal. And then if we need more information, we'll go to the client. We will ask them to provide us more information. If they they can use self-attestation at that period, at that point. If they need provider verification, they would then go do that. They were doing a 12-month exclusion duration. So and that is allowed in the rule that's the longest exclusion that you can have. So someone who's living with HIV, 12 months is the longest that they would be able to be excluded from the work requirement. And then it has to be reevaluated at the end of 12 months. And then, you know, exemption stacking, it's a little unclear how that will work, but if you qualify for more than one exemption, of course, we want to make sure that you are able to, you know, to use the ones that will get you the longest exclusion or exemption. I see a question about what's the difference between exclusion and an exemption.
No. We're not doing that, Rachel, yet.
Oh, okay.
Yeah,
All right, next slide.
actually, I need you to kind of wrap up in like 2
Yep,
minutes, and then we
I'm
can
almost done.
exactly where you're going.
Yep.
Okay, good.
I have, I think, 2 more slides, but I can do them very, very quickly. What does success look like is our next slide. And basically it just looks like a policy that will exempt the most people and do it by preserving, and if you can go to the next slide, by, you know, preserving people's privacy and dignity. And then we can go to the slide that says, what can we do? Which is basically pay attention to what's going on in your state, weigh in, and let us know. And I will wrap up there.
Rachel, before we go to the chat, and I'm sure Mark will help me, I wanted to ask you, do you have a list of the states where people can, you know, contact a person or organization that may be working on this issue? what do you suggest for folks who want to connect statewide? I mean, within their state to help?
With other advocates,
Yes.
you mean? So there is a Medicaid coalition in almost every state that, that is working. And I don't have a list of contact information right now, but I can certainly direct people to others in their state if they would like that.
That would be great. And just want to thank you again for that wonderful presentation. There are a couple, I think you flagged one, Mark. Are there any other comments, questions?
Alicia asks, why are Indigenous people automatically exempt from this requirement?
Indigenous people are exempt from most of the requirements because there are a whole different set of rules that apply to Indigenous populations. And then there was another question about the difference between exclusion and exemption. An exclusion, if you're excluded, this requirement doesn't apply to you, period. If that means you are not subject to the Medicaid work requirement. If you're exempted, it means that you are subject to the work requirement, but you've got a temporary reason why you don't have to meet those qualifications right now.
That is great, Rachel. And if it helps with the Indigenous person's question, that folks are considered to have their nation. They are nation people. They're
That's right.
governed under different rules.
Yes.
And then we had Trevor. I wanted Trevor, while you were available, Rachel, to talk about what's happening in Michigan. Maybe you already know and you don't need to know that, but I think I like it because he could actually tell us who he's working with, and maybe he is the one, and then how they're coming up with the different data. Who is
Yeah.
helping them inform which data to use? Trevor, would you like to come on the screen?
Rachel, thank you so much. Rachel did mention that some states have MOUs in place that allow Medicaid and like the Health Department Bureau of HIV, for instance, in my state, work together around data. Um, the Bureau meets very closely with the leaders in Medicaid to just openly have conversations about what's going to make sense and what's going to help preserve Medicaid for the people who should be excluded from those work requirements. So we're looking at several things. Not only the diagnosis data, but we're also questioning whether there's some data from the Ryan White program that could be leveraged as well to help show that somebody's condition impairs their ability to work
Thank
or
you.
meet community engagement.
Rachel, any follow-up? Any others have on the line who have questions? Thank you, Trevor. Appreciate you. Thank you. Rachel, I'm going to ask you one last time. Is there anything else you would love to share with us? Because I do have a question for you.
Go for it.
The information that was on your slides, is
Mhm.
that like a electronic handout somewhere? Or are you just willing to share the slides?
Oh, I'm willing to share the slides. Yeah, we can share them.
Okay, because maybe we could do something with those. Thank you. Kelly has her hand up. Kelly, go ahead.
I know I'm supposed to be on the panel that comes on next, but Rachel, I have a question for you. I feel like I always do. Okay. When feasibility of state implementation eventually runs up against federal deadlines, like there's going to be a point where the states just aren't able to get where they need to meet what the federal government is requiring. The federal government, it sounds like, is not going to be moving very much on giving states more time to implement. So what happens in that collision point?
So here's what I think is going to happen. And I'm, obviously prognosticating gets people in trouble these days because the world is a weird place. But I think what's going to happen is that states are going to have their compliance systems set up with like, have you met the work requirement, right? And the part that's going to be lagging is, do you not have to meet the work requirement? And so I think what they're going to end up having to do is that they're going to be preferencing this system of did you or didn't you, and then it'll be up to the individuals to say, but wait, you can't cut me off because I shouldn't have to qualify, right? And I shouldn't have to do that. So I think that's where the mess is going to come in. We know that these systems are messy. We know from Arkansas, from Georgia, and other experiments that people who, even if they're meeting the requirement, they are, subject to getting cut off because for administrative reasons. So I think it's going to be that administrative issue that we're going to run up against.
Thank you. And that leads us right into community impact. Rachel, thank you again. We're glad you're staying. Please add whatever wisdom you would like to add in the chat or raise your hand. Thank you. So, panel, are you all ready? We're going to highlight Barb, Kelly, and Gabriel. And we're going to go right into community impact. I'm not asking you any questions. You all are always on top of it. And I'm sure you already have thought about what you want to say in that regards. So how about if I start with, so we're going to spend about, each of you will spend about 3 minutes, and then we'll have some discussion, and then we'll open it up for Q&A. We'll close it, and then we'll go into advocacy and action and redo the same thing. Does that sound like a plan to you all? Great. So Barb, why don't you get started?
Yeah, thank you, everyone. And thank you, Rachel, for your presentation. Every time I listen, I learn something new. One point that I did ask is, how are we proving that people are unable to work? That additional component is going to be terrifying. So when I talk about Medicaid work requirements, and especially our work around proving that people are medically frail, or as I like to call it, chronic health conditions, because medically frail is somebody who's been living with HIV for 35 years, gives me all kind of feelings. So this is going to be terrible. I don't want to frighten all of us, but I do want to lift up that this has the potential to be really terrible. We talk about red tape, and I actually have talked about funding, but also Medicaid work requirements and the confusion and the chaos around it as this impending doom. Because, and the reason why I say that is that we're talking about paperwork. We're talking about lots and lots of paperwork that's not particularly clear, that's not easy for people to access, that is not easy to submit, especially to Medicaid offices that have suffered significant reduction in workforce. And so the advocacy that we need to do is we need to push back until July 31st to make sure that this is lifted up and that everybody is aware how terrible this is going to be. We need to educate our community so that people know this is coming, so that they can start gathering their paperwork and start figuring out how they're going to meet these needs. And we need to make sure that we continue to talk about it. Because as we've said, 42% of people living with HIV are on Medicaid. And with these impending requirements, if people are dropped off of Medicaid, then they're not able to access Affordable Care Act premiums or policies. And then they're going to go to state ADAP programs. And we've learned in other advocacy spaces that ADAPs are significantly challenged here as well. And so I don't want to be the bearer of doom and gloom. And I feel like we have advocacy opportunities to really turn this around. But this is something that is critical for everyone in our community. The hard-fought gains that we have been able to lift up over so many years of advocacy are in danger, because if people don't have Medicaid, they're not able to access health care that talks about both their HIV as well as their other chronic health conditions. We need to make sure that people continue to have access to that, not just the medications, not just for HIV, but really for all of these comorbidities, because we're aging with HIV as well. So I really encourage everyone to think about how you as an organization and how you as individuals can be educated about this and make this a policy advocacy priority. Because here's the thing, in Colorado, I just want to say, we have been working with our Medicaid division for 9 months about making sure that HIV in all of its permutations and categorizations were going to be on the medically frail chronic health condition list. We had 2,000 of them. We went through stakeholder processes. We were looking at forms. We were implementing all of that. Now, because of this additional proof that you are unable to work, most of the people who would have been able to pass by this work requirement are now going to need to scramble either to work or to figure out how to make sure their volunteer hours are qualified or that they are enrolled in a learning opportunity. So we need to lift this up as a real challenge that it is. And I'm going to stop there.
Hey, thanks, Barb. That was excellent. I think that folks are learning that people have been in the background doing a lot of work to try to keep this onslaught from happening, and that they keep changing the rules in the middle of the game. So, with that said, we're going to go to Kelly and then Gabriel. Kelly.
Sounds good. Thanks, y'all. Hey, everyone. My name's Kelly Flannery. I use she, her, they pronouns. I'm the policy director at Positive Women's Network. I get the utmost privilege of working with Barb and Gabriel through the USPLA HIV Caucus Policy Strategy Committee. Yeah, I just think a huge +1 to everything that Barb said. One of the things that I think about a lot, and I've been trying to change in the ways that I talk about this, is that, you know, the federal government is calling it a work engagement requirement. We call it a work requirement. This is really a work reporting requirement. It's not about actually getting people to work. It is about kicking people off of Medicaid because they're not able to document that they're able to either meet an exemption or that they've worked the hours that the federal government is requiring. And so I really try to emphasize it, and Barb got to this too, right? It's using red tape in order to kick more people off of Medicaid. And to bring us back a little bit to where this came from, the why of them doing this came from a bill called HR 1. Some people call it the Big Beautiful Bill. Some people call it the MAGA Murder Bill. Some people call it the Big Ugly Bill. I'm going to call it HR 1. And what happened in HR 1 was that Congress gutted Medicaid and SNAP, including adding these work requirements, in order to give tax cuts to the uber wealthy and corporations and to super fund Trump's immigration, deportation, and detention machine. And so what we often say when we're talking about the federal budget is that it's not that we have a resource scarcity problem. It's not that we don't have enough money. It's about where we're distributing money, right? And so a big part of the demand needs to be that Congress invest money in services that actually keep people safe, in healthcare, in housing, in education, instead of giving enormous tax breaks to the uber wealthy or pouring money into systems of incarceration and state violence. So that's like just a little bit of tangent. But I did, like, losing coverage is the point. Quote unquote, saving money because more people are losing Medicaid is the point. I'll also just name that work requirements themselves have a deeply racist history that we need to reckon with. This is essentially anti-Black, right? Black folks are going to be the folks who bear the burden, who are kicked off of the Medicaid program unjustly because of this utmost demand to have to prove that you are working or prove that you meet an exemption. So really focusing on who's going to be the most impacted. It's going to be the communities that already have the most barriers to accessing healthcare. It's people living with HIV who are also Black, queer, trans, immigrant, Latinx, sex workers, drug users. It is going to be the folks that society has already pushed to the fringe. And so when you're pushing back against this work reporting requirement, really be clear that we are doing this because we care about equity. We care about racial justice. We care about liberation and safety for our trans communities. And this is a part of that fight. This is a really important part of that fight. And Gabriel, I'll pass it to you.
Thanks, Kelly.
Thank you. I mean, really difficult acts to follow. Hi, I'm Gabriel. I use pronouns fluidly. And yeah, what else is there to say? I like the your tangent on money, Kelly, and like follow the money, because for states that have already implemented work requirements that were mentioned in the presentation, the costs of implementing just the monitoring of the work requirements varied between 10 million and 270 million. And so it is incredibly wasteful to implement these systems. We know they're not going to happen quickly. Most of this money, 80% of the costs, goes to consulting fees to pay for, rather than paying for healthcare. And so it does beg the question, one, how are states going to implement these things effectively, which they're not? A lot of the coverage is going to be lost through the process of either proving an exemption or continually proving, if one has to continue renewing the exemption. So all of the reporting is going to jam the system. That's how they're going to drop people effectively. I just wonder if there's anything that advocates can do to have states sue instead of reactively, proactively, and telling CMS and telling the federal government that they just don't have the money to implement this adequately. I mean, this is something that has been documented fortunately in other unfortunately in other states, that people with disabilities have faced in the past, people with lots of chronic health conditions. So there are communities and there are places that have been studied where this has been implemented in the past, and it has caused loss of insurance, it has cost people's lives. So perhaps I mean, yes, it is a pretty dire picture. But I wonder if because the states that are facing this are the Medicaid expansion states, if they would be more willing to make a coalition or something where, there could be a big lawsuit. I know that there have been retroactive lawsuits when states chronically fail to meet deadlines to implement assistance programs and so on. Like New York had a famous lawsuit with HRA, legal aid sued HRA for chronically fail to make decisions on food stamps for people. They had a big class action lawsuit. But those are going to be band-aids like down the road. I wonder if proactively we can just have states from the get-go say, we don't have the ability to do this.
Thank you. Thank you. That just Kelly, did you want to respond to something at this moment? Okay. Gabriel, thank you so much for that. Different perspective. I love it. Love it. Go ahead, Kelly.
Yeah, I really appreciate those questions. I will say that I think we're getting to advocacy, but PWN, the Sierra Project, the U.S. People Living with HIV Caucus, and the Save HIV funding campaign are going to be hosting a phone bank, specifically to try to motivate folks to call Congress, to try to use congressional power to pressure CMS to pause this rule, right? To say, this rule is not workable, pause it, go back to the drawing board, give us something that will work. Another part of that, Gabriel, to your point, what you kind of like made me think about is that we're also layering another component on this where we're asking folks who joined to call their governors. So we actually had someone go and find governors' offices, so that the idea is that governors can also try to add that extra layer of pressure onto CMS to say, like, we actually can't do this. We can't implement this. It is not financially doable. It's not in the best interest of our people. So really trying to use all levers of government to put pressure on CMS to stop this absolutely terrible rule. And the other thing I wanted to just name, because I pulled up these stats because I thought it to be like, it really shocked me, but like states have tried to implement Medicaid work requirements. And so in Arkansas, when they tried to do this, 4,000 people lost coverage. In
No,
I'm
no,
sorry,
no. Keep going, Kelly. Keep going.
18,000 people lost coverage in Arkansas before they were required to pause the Medicaid work requirement program. And so it's not even as though the federal government can act as though they think they're implementing good policy. This is proven failed policy if by good policy, what you mean is keeping more people insured and expanding health insurance.
No,
And
that's excellent. Before we get to the advocacy piece, I want to thank all three of you for giving us an overview of what the impact may be and give opportunity for people in the audience to ask any clarifying questions, comments, or concerns they might have based on what they've heard, either from what Rachel said earlier or from what these three brilliant advocates or community leaders have said at this point in time. Okay. Then what we're going to do is go to the advocacy portion of our program. And I've already put some questions in there so that can prompt some of you, three of you, or people in the audience who might want to ask one of these questions later to get the information we need. So I'm going to go in reverse order this time. We started with Barb, Kelly, and Gabriel. Kelly, you still end up in, I'm going to mix you up too. Gabriel, Barb, and then Kelly. Okay, go ahead, Gabriel. We're talking about advocacy now.
Okay, and the question would be, what should people do if they receive a notice about Medicaid eligibility reporting? Are those the questions we're looking at?
Well, you don't, there's a series of 5, and one is what should a community organizations be doing to protect their clients in regards to these Medicaid work requirements? There, what should people do if they receive a notice of eligibility reporting? That might be too early. Another one could be how can organizations prepare their staff and communities for possible changes. That one is what you all have been covering. We really need the information on what do we say and how do we help people who come to us who have questions. And I kind of asked Rachel in the beginning about her documentation because that would be good to make community wide. It would just be great. So, from whatever perspective you want to answer the question, Gabriel, please do so.
Yeah, I mean, the most important thing that probably HIV organizations can do is to find out how does a person with HIV claim an exemption, right? Because there's not going to be a blanket exemption for people living with HIV. So how can they claim an exemption right away and then figure out how to move from there? Like the first step has to be how to keep people insured, right? And so perhaps the system will collapse before they even get to check what's happening, but really make sure that that self-attestation maybe gets used right away so that people can then work with the new documents and their reporting systems to get their doctors to write them the proper documentation. I mean, for folks who aren't in care, because we have to think about all the scenarios. Like people are going to have to visit specialists and people are going to have to visit again their like primary care and insist that their forms get filled out. And so I think the first line of defense, so to speak, would be the exemptions and the self-attestation and anything that can't just exempt people from these reporting up until the point that they actually have to. So it's just like they do, delay, delay, delay.
So let me throw in a question for all 3 of you. And this might be antiquated data, so Mark, please tell me to be quiet. But this is in regards to how they do Social Security determinations. Are we going down
Mhm.
that same path where we're going to have to collect that documentation in order to determine whether or not we have a disability? Well, I'm not quite understanding. And what happens if they say you can work? Does that impact your Social Security or any other financial income you might have from the government?
Hey, Vanessa, I just want to jump in because I think that's such a brilliant and important question at the center of this discussion. And I'm wondering if Rachel would allow us to bring her back for her understanding of how folks are going to need to and be able to provide documentation that may result in exemptions when they're possible.
Yeah, so let me first address, I think one of the questions that you asked, Vanessa, is about whether being determined eligible or ineligible to meet this requirement or able to work is going to affect your other income from Social Security, et cetera. And I think the answer to that is no, right? Like this is a separate determination that is just for Medicaid eligibility. So I think the key here is that under this current rule, we can't just say if you are living with HIV, you're exempt, right? There's this extra subjective test. And so I think the real impact is that people who are living with HIV who are working are not going to be able to argue that they can't work, right?
Mm,
For the most part.
mhm.
And we're going to have to deal with what happens as someone may get sick or have other issues, you know, in the middle of things. But generally speaking, if you are working, you're able to work, right? So I think that means we have to have some system where we can help folks navigate that requirement and be able to demonstrate that they're working so that they don't risk losing their coverage. And we're helping people get through whatever the administrative barriers are. I think that's going to put a lot of extra work on Ryan White caseworkers and others who are going to have to help their clients through that. Then there's a separate piece of for folks who are not working or who are not able to work as much as the 80 hours a month or $580, how do we show that they are not, that they should be exempt, right? And we don't know the answer to that question yet, because states just got this marching order a couple of weeks ago and they haven't figured it out. And so that's part of what I think we need to go back to states now and say, oh my gosh, you guys just got this impossible task. It is impossible, by the way. But here, let us give you some ideas about how it could best be administered. Namely, let's use self-attestation for year one, right? Make sure you put that into place. Make sure HIV is on your list. Make sure viral hepatitis is on your list. And then let's use self-attestation to the broadest extent possible for 2027. Then we can worry about it in 2027. Let's figure out what the rest of this looks like. I think that's where we need to be.
That did not make it any easier, but okay.
It doesn't, because it's an impossible assessment, right? It's entirely subjective and invasive and, inappropriate.
Thank you, Rachel. Any of the three of you want to follow up or raise another issue? Thank you, Rachel. Appreciate you. Barb or Kelly?
Yeah.
We can move on if that was a great point you raised, Gabriel. Thank you for doing that. And all the chat about the person hours that will be required to ensure that folks stay protected.
Yeah.
So
Yeah,
Barb
thanks
or
for
Kelly?
that comment, Rachel, about the fact that we don't know how people are going to be proving that they are unable to work, because that is really this extra kind of sucker punch that just came out. And, like I said, states like Colorado that really want to protect people who are on Medicaid and who have chronic health conditions are really struggling to both not, make it so hard and impossible for people, but also to follow along with the regulations. And it's going to be really problematic. So one of the things that I want to talk about around advocacy is community. Y'all know I always talk about community. And so what's going to be the most important thing is that allies and people living with HIV talk to allies and other people living with HIV and ask them if you are on Medicaid. It is something that oftentimes people feel really stigmatized about or shamed that they're on Medicaid. And so, I now am asking every person I know, I'm not making an assumption about who might be on and who might not be on, because I want to make sure that everybody knows that this is coming, that there are advocacy opportunities up until July 31st, when this interim final rule is actually implemented, for us to push back. And so it is about, advocate with making sure that our public comments are submitted, making calls. It is educate our community, asking questions, inviting people to say that they don't understand it, that they're going to need help. And so we actually have started scheduling community groups where we sit down and we just sort of say, how are you doing? What are your challenges? How do we work together? What do we need to do? That's going to be really important. It's back to those days where people were being, prescribed medications and they didn't quite know what it was supposed to do or how they were supposed to take it. And we trained each other up. And so this is a call to advocates and to organizations with advocates to be able to start implementing that. And then the other part that I want to lift up, because I know there's a lot of organizations here, is we need to make sure as organizations that have people who volunteer with us and do work with us, that perhaps is subject matter expertise, is unpaid labor, that we are developing ways to track those volunteer hours, because that can count as this community engagement. And so at PWN, one of the things that we're actually starting to develop is how do all of our members who do amazing work representing people, and especially cis and transgender women, gender diverse folks, and transgender people living with HIV in our community, how do we track those hours so that we can then give them a determination that they have worked those hours and can then provide it if necessary. And so that is an invitation to organizations to start thinking critically about your volunteers and how to support them through this as well, because it's
Wait, Barb,
complicated.
can I ask you a question?
Yeah,
Are you all going to get advice from your fiscal sponsor? Because that would be great.
yeah. We're getting
Can you
advice
just
from our
share that?
fiscal sponsor as well as, another, a bunch of other nonprofits that are looking at perhaps doing this also. And so we are, yes, we're happy to share that, but that is something we need to do, because if this comes along, we can actually be part of the solution as well. And we are happy to share that once we figure it out. And I'm done there.
I don't have anything to add, but I want to give us like a high level recap of advocacy points because a lot of things were just thrown at folks. I'm going to do my best. So, Barb, Gabriel, Rachel, correct me. So, we have this delay strategy. Push back on CMS, use governors, call Congress, do what you can to try to get CMS to delay and rethink this rule. At the same time, we have to be making an assumption that this rule is going to be moving forward because states are doing that. So you have to do harm reduction with your state. You have to work with your state to make sure that as they implement the rule, they're doing it in the least harmful way possible. They're making sure as many people as possible can stay covered with as little barriers as possible. Also, again, unfortunately, assume states are going to get there, they're going to implement the regulations, then figure out with your people in your community, what do you need to have in order when these work requirements hit? If you are a person living with HIV, how are you documenting that you should be exempt or that you're meeting the work requirement? If you are an organization, how are you setting up structures so that you can make this easy for people to show that they volunteered for you, they worked for you, whatever those processes are? I think that's kind of like the 3 steps that we have to be thinking about right now.
Can I make a friendly amendment, Kelly, which is that as we go forward and this starts to get implemented, we need to be documenting. We need to know who is hitting those barriers and what is happening to them as a result. And we need to keep highlighting that damage that is being done and sharing our stories with all of the elected officials who are involved.
Agree.
Can I add one additional? This is
Yes, please.
just sort
The
of a
floor is all of yours until somebody from the audience wants to ask a question.
okay. One of the things to be really clear about is that every state is going to implement this in a different way. Every state is going to have different documentation. And so when we are talking about it, it is important for people to also to know that we have a general outline, but that it will be different based on every single state that they're in. And so it is even based on, as it was mentioned in the chat, that states' Medicaid programs have different names. And so sometimes people don't even know if they are on Medicaid. And so it's important to be able to also lift that up as well.
And I am seeing some really excellent insights as well as some questions from Tyrone, from Mary, from Julie, from Trevor, and I'm missing some names there, but I just want to invite any of you to come off mute to come on screen if you'd like. We could go to full gallery mode for discussion and Q&A and comments.
Oh, I think that'll be great, Mark. And you are the person to lead
And
it.
Tyrone has raised his hand.
Okay, but let me do something first. There was
Oh,
5
okay.
points that you all made. The panelists made, Rachel, Gabriel, Kelly, and Barb. The 4 of you made. And is there any way you could, everybody just, like Kelly, you started it off and then Rachel added one. Can y'all put that in chat? Okay, thank you. All right, go ahead, Mark. Or okay, Ty. There you go. All
Hey
right.
y'all, thank you. I have to run, so thank you for taking my question. So, on the piece around state advocacy, is there like an easy list for state advocates to see like these are all the specific ways that you can be pushing your state to make this like least restrictive possible, so they know like kind of like a checklist?
What's interesting is I asked that question as well in another call that I was on, and the answer from another organization was we're working on it. So I think it's a watch this space. Excellent question.
Yeah.
Awesome.
And for the moment, I would suggest you visit KFF where they have this survey that they did about what states are planning, because it does sort of show you what some of the options are that states have and how many of them are pursuing them.
Thank you, Rachel. I want to flag something that Julie is saying too. Julie, do you want to come off and just say what you are saying about the different names, or do you want me just to read your comment?
I can say a little bit.
Yeah.
So folks locally have a Medicaid access team, and some people at one of the hospitals have been doing a lot of good work on this. And they were talking about the fact that in community, when they talk to people, they don't always know that the insurance they have is Medicaid. So they don't have any idea that this has them in any kind of situation around work reporting requirements. And so they started asking, I think we have 5 different companies. And so I offered a couple like Buckeye and CareSource. So when they ask people that, then they can dig a little deeper and say, well, yeah, actually that is Medicaid. And let me tell you what's going on. So
Yeah, I think that's a really good, important part, especially following up on Tyrone and his question for state advocates is to find out the names beyond Medicaid. Great point. Yeah, I see Barb's hand up. I see y'all. And if Kelly, Gabriel, or Rachel, you want to come back, please raise your hand. Barb.
Yeah, one of the things that actually I want to lift up as an advocacy for state-based advocates is to reach out to your Part A and your Part B planning councils and make sure that they are aware that this is coming. Many of them are not, and to ask them, so maybe to have a little conversation with them and then to ask them to reach out to their state Medicaid division, because that is how you can get connected with the people who are writing these rules, implementing them, and they definitely need to hear from us. So that is an opportunity based in your own particular state about ways that you can really make sure that this is a part of the conversation moving forward. Rather than waiting for a national group to try and connect us. You probably know people in your state who are on the Part B Planning Council or even the Part A Planning Council, and it's time to really get them motivated around advocating here as well.
Excellent. And then we have a brain twister for you all in chat, given by Paul. I do not understand what he's asking, but I know it's important. Can someone address that, please? Read the question first. Then
Paul, do you want to come off, Paul? I
okay,
thought
great. Thank you, Mark.
you brought up a great point.
Yeah, I can come off at least the mute button. So I guess looking back on I guess it was Rachel's presentation about possible exemptions, optional exemptions, whether that applied. There was one about unemployment rates, and although it looks initially like that's for a geographical area, communities that are not necessarily geographical areas and yet could have very different unemployment rates than the general population. So that's the basis of the question. And
Rachel, you're
Rachel's on
muted.
mute.
Here we go. It's geographic. I don't see this administration allowing any other kinds of definitions of that by looking at specific demographics, for example, or certain non-geographic communities. I think they're going to stick with geographic, and they seem to really object to anything that isolates people in other ways, right? Or that describes people in other ways other than geographic.
Well, the only thing about that is that it isn't just the administration. We're talking now about legislation, and I'm wondering whether it's possible to interpret the law that way, or whether a state would be justified in at least making that challenge.
It's a really good question. I don't think so from the way that it's drafted, but I think it's something that we could work on in the future.
But not only that, I want to raise something and go back to what Kelly had stated and really have a great discussion around one of our strategies. I agree our strategy is going to have to be multi-level and cover a whole hundreds of things. But one of the things that struck me about the ACA when they were really trying to bring it down at the beginning of the administration is that they took it from being just a one population issue. Like, for example, yes, I truly agree with you, Kelly, that this truly is anti-black, but it's also anti-woman, it's also anti-group, everything you said. So what happened with the ACA in my mind was that we were able to elevate it so we could make it seem so it was realized by everybody in the country, you're talking about me. You mean you're taking away my coverage? At some point in time, we have got to get everyone who's affiliated or tied to Medicaid thinking the same thing. Otherwise, we're going to be doomed, and every state will be different, as they are going to be anyway, but not to the degree that they could be if we just kind of. Kelly, answer my question. I know you know my question.
I didn't mean to, I was just putting myself in stack because this is something I've been thinking about a lot. So use
Yeah,
please.
no, go ahead, please, as I've expended it.
I wanted to name that this actually didn't come to my brain. Antoinette Jones, when I was having a conversation with her about the Medicaid work reporting requirements, named this. She was naming that like they specifically targeted Medicaid expansion states. I think it's really important to understand that, a couple of years ago, they were coming for the ACA. They were trying to repeal. It failed because folks love it, right? It is really hard to take something away that gives folks an essential human need once they have that human need. So now what they are doing through things like HR1, through things like work reporting requirements that specifically impact the Medicaid expansion population, which the ACA created, is chipping away at the ACA. They're doing it more silently. They're doing it in a sneakier way, but all the same, they're trying to undermine the ACA and make it such that ideally in their circumstance, right, they can point to it at one point and say, it's not working anymore. Let's just get rid of it. Right there, that is strategy right there. And it gets to a point that I've heard folks say, like, oh, good, I'm not an expansion state. I don't have to worry about that. Right. And that's a complete flip of the script. Like, yeah, sure, you don't have to worry about Medicaid work requirements because you're not in an ACA expansion state. I'm glad that you don't have to worry about them. I'm so sad that you haven't expanded Medicaid to more people in your state at the exact same time. And so I think we need to learn how to fight at our core for expanded healthcare access at the same time that we're talking about these nuances. Excellent question, Vanessa. Thank you.
You're so welcome. An excellent response. Thank you. I now have something in my head I can say. Okay, good. That's what I had. Barb, did you have your hand up? Did you want to add anything? Rachel? Gabriel? So I'm going to ask everybody that's online because we have about 10 minutes before. Don't let this 10 minutes leave and you haven't asked, yeah, you haven't gotten the one thing that you feel you need. Needed. Like Tyrone came on and talked about state advocacy. Other folks talked about how to refer to Medicaid so people know that you're talking about them. Anything else you think as a community we need to start preparing for battle? Because this is a battle, it is a war. Been one for a long time.
I I would just like to say that I mean it's really good. The person who spoke about from Michigan. Sorry, I'm having a cognitively challenging day. The person who spoke about Michigan, like sharing information, like we need to start doing that type of advocacy at our state level. I know from working with low-income students to keep their benefits while they're reporting um, these work requirements or to keep their benefits. Some of the ways in which the Welfare Rights Initiative, which I worked with, was advocating with the state and with the body that is collects that data, is to find ways that were less invasive to students, to protect their privacy and not out them as low income, right? Because at some point they were having them go to professors and having them sign forms to make sure that they were attending classes and they were in good standing, when having a Pell Grant sufficiently demonstrate that you are compliant with your requirements as a student in the school. So then that became an issue that then the lawyers had to take up. And so it does take a long time. This is like a really slow political process, but finding those organizations that have already been advocating for people who were affected by work requirements from 1996, since the personal work and in welfare reform, basically. Since then, there's been organizations in each state are advocating for different populations to keep their benefits. And so this is when we really need to coalesce with other communities, like Barb said. But yeah.
Oh, excellent. Thank you so much. Before we go to Julie, does anyone add any additional remarks or comments to what Gabriel said? Which I thought was great. Yeah, we have been through this before. That's what I heard.
And can I just add that, at the same time all of this is going on, there are like new, even more harsh work requirements being added to SNAP at the same time. And so, there's a lot of overlap between people who are, relying on SNAP and people who are relying on Medicaid. And I think we need to be remembering that, especially in a structural interventions, working group, that we're looking at restrictions on food, housing, healthcare, et cetera, all at the same time, and start showing the sort of how each of these things compounds the other.
Absolutely. Absolutely. So one of our last comments or questions will be Julie, and then I'm going to turn it over to Mark, who's going to close us out. I want to thank you all for having such a wonderful, thoughtful discussion around Medicaid work requirements. I don't feel so helpless anymore. Thank you very much. Information is power. So, Julie, are you ready?
Yeah, I was just putting it in the chat too, but essentially I was thinking about the fact that we have folks who are Medicaid advocates more broadly in the community, and it's really like our local ACT UP, and people living with HIV seem to be much more worried about ADAP and the collapse of our state ADAP. And it's like we don't always connect the dots the best way between them. There's a sense of separation. I wondered if you all, I know that I've heard really good things before about, 40% of people who live with HIV are on Medicaid, and especially with the expansion, I think we've been learning how many more folks, right? Was it 42% or something, Rachel, in your slides?
Yep.
I just think we need to keep doing that because there's a sense of separation, like we're fighting
Yes.
two separate fights, and nobody's, well, not nobody, but it feels like it gets lost. And I just keep thinking about this cascade or the
Yes.
squeeze. I think people
That's
call it
right.
the squeeze. So people are going to be falling out of one system into the other, going for uncompensated care in our local Ryan White providers, and they're going to end up having to get emergency financial assistance and just bouncing back and forth, and getting lost. And I don't know, what are your thoughts on that? It's kind of seems like a piece that is maybe missing.
I think that is such an important piece. And it's important on the individual level, right? Because we're going to start to see people who are in search of the next layer of the safety net, right? As they're losing some pieces of it and falling through. And then on a macro level, this is really important too, because we're already starting to see cutbacks in ADAP just because of what's been happening with ACA premiums and restrictions, right, that are going on there. When we get to Medicaid, this is like what we're seeing with the ACA stuff is just the tip of the iceberg in the impact on Ryan White. And when people start losing Medicaid, Ryan White is going to be losing reimbursements and having to take care of more people who are uninsured. And that means that all of those, all of the stable funding that we have been receiving since 2014, when we had our last big, meaningful increase in Ryan White funding. The only reason that Ryan White has been able to maintain and even increase care over the last decade is because of Medicaid expansion and the ACA, right? And rebates, but goes hand in hand with the ACA stuff. But the fact is that we're going to start to see a restriction in funding that is going to Ryan White. And that is going to have a big impact outside of Medicaid, outside of Ryan White too, right? Because if Ryan White is not able to accept more patients and continue providing the same level of services, then people are going to go to the next place. And where is that? Your local hospital, emergency rooms. And we're starting to see a lot of cost pressures. Not starting, we've had ongoing cost pressures for rural hospitals and small community hospitals for quite some time. So there is a cascade here. It is very clear. And I think we are going to be seeing more and more states putting restrictions on their ADAP programs as all of this progresses. And I think it is incumbent upon us to make this case to policymakers and to show them, you know, when you remove care from people with HIV through Medicaid, the people don't go away and neither do their healthcare needs, right? That has to get absorbed somewhere else in the system. And those are, you know, places that are going to be really stretched as a result of this. So, you know, that's part of the documentation here. And we have to be the ones who are drawing those dots together for policymakers so that, you know, they can see we need increases in funding, we need to reverse these cuts, and we need to refocus on what's important.
I agree. And on that note, I leave you all with this. What's the sense of having a social contract when it doesn't work? What is that? And why are we still safety netting people when we should be landing them safely? There's too many this country has an abundance of resources. We just saw how many billions of dollars have gone all over the world. Oh, they can come get me. I must say it. Why is that money not being spent here? We can save the world and ourselves at the same time. I think we're very capable of doing that. So, on that note, I want to thank the speakers and attendees. Medicaid work requirements can create serious barriers to coverage and care, especially for people already navigating poverty, illness, caregiving, stigma, unstable employment, and just about everything else in life. We want to thank Barb, PWN USA, Kelly, PWN USA, Gabriel, he is from the caucus. He's not from PWN USA, but they're all part of that ball of wax. And Rachel, who is our ally in the community with the AIDS Institute. And I hope we all come back. Would you all say, at least for the moment, you would consider coming back in the fall to do a part 2 of this to see where we are?
Anytime.
That's excellent. Mark, you want to say goodbye to
Oh,
everybody?
I want to
Thank you
say
for
thank you,
being
Vanessa, for
here.
getting those agreements.
Uh-oh, I think
That's
I'm
awesome.
frozen.
Oh, no, you're good. I just want to ask Rachel, can we share
Hello,
those
is everybody
slides?
still there?
We're still here, Vanessa. And yes, I'm happy to share the slides.
Okay,
And
great.
Kelly, you outlined what I thought was a very helpful articulation of 4 key directions to work in. And can we share that also in that email?
Absolutely, please
Uh,
do. Just include
And
the phones app.
Yeah, we'll do that
yes,
again. Say that one more time. You have 30 seconds.
I said, include the link to the phones app. Really, really join us on Thursday, y'all. It's a really fun time. You come together, you act together, and you leave knowing that you have done something in community. So please come, please share.
yes, if you're not 100% sure that we have your email address to receive these emails, please put it in chat or email me at mark@workingpositive.org. Thank you, everyone, for joining us, and thank you for letting us keep you a minute late. Thank you to the brilliant folks on this panel. Really appreciate you
Thank you.
tremendously.
Thank you for
Bye-bye.
having us.